Hi, I'm Dr. Randy Martin here at Mount Sinai. We had an interesting discussion about arrhythmic mitral valve prolapse in part 1, but now in part 2, we want to talk about a case and really look at the new knowledge that we've gained. You've helped me out a lot to understand things, and now I want to know more. I want to see a case and know how I should be working these people up.
And this is a brand new case, so it's perfect timing. This is a 55-year-old female, was seen for occasional palpitations by I think first an internist and then a cardiologist. They did an EKG, or they did an exam. They noticed there were some extra beats, so they decided to do a Holter monitor. Performed the Holter monitor, the PVC burden was about 15.9%, which is moderate, which is less important to me than on the actual Holter. She had evidence of couplets, non-sustained VT, and at least 2 different morphologies. Again,
so it's complex
ventricular ectopy.
Mark, sorry, so the patient came to the doctor because of the palpitations?
Just for the palpitations, yes.
Okay. That's important because there's got to be something that will get you there.
That's usually what, I mean,
otherwise these patients early on, they don't have a reason to see a doctor.
Correct. Had no diagnosis.
No. Okay, so she gets an echo.
Then they decided to do an echo because they saw the PVCs. She had bileaflet prolapse, mild MR at best, and they did note mitral annular disjunction about 13 millimeters.
So it's getting into the range where you were more concerned about it.
So this is an advanced prolapse already. So you have this junction. We know it's not in its nascent state. It's been going on for a while, despite the fact there is no regurgitation yet, which is important to you.
Yeah. Okay, got it.
So then this is just an example of the 12-lead EKG that was done. So this is a 12-lead EKG. We look at this EKG, and the first thing we try to identify is what is the source of the PVCs. Is it in the left ventricle? Is it in the right ventricle? Does it involve typical structures? So in this particular scenario, what we notice, besides the fact that there's couplets, which is always concerning, is that one of the PVC morphologies has a right bundle branch morphology with a superior axis, which to us usually indicates that the papillary muscle is involved. But this PVC is originating from the region of the papillary muscle. What's also interesting is that if you work further down the EKG, there's a second PVC morphology shown here. And if you're an electrophysiologist, what you'll notice is, and if there's any electrophysiologists watching, there's a QR pattern there. A QR pattern usually indicates the aortomitral continuity. Again, another area that's exposed to stresses.
So now you've got 2 areas that are causing these PVCs.
We have 2 areas that involve the mitral annulus, which are giving off PVCs. So there's actually recent literature where they took a whole series of patients with mitral valve prolapse. They put them all on treadmills. They ran them in order to induce PVCs. And what they showed was that the majority of the PVCs were coming from the papillary muscle, but at least 1/3 of the PVCs were related to the mitral annulus, whether or not it's the AMC region or other areas in that aortomitral continuity. Again, these are areas that are probably exposed to the forces of the mitral valve.
And Mark, do we know if this patient had normal coronary anatomy?
Presumed to be.
Okay.
So that's another context that we need to point out, that the presence of this ectopy in these patients are in the absence of other structural pathologies. So the patients have normal coronaries, and they don't have channelopathies or other abnormalities for the conduction system.
Okay, so this EKG is worrisome.
It's concerning in someone with prolapse. I mean, it would be concerning to me in someone without prolapse, because why should you have couplets and that sort of, and 2 morphologies? So because of the presence of what they identified as 2 risk factors, which is complex ectopy and significant mitral annular disjunction, 13 millimeters, so it's not an overcall. They referred the patient for a cardiac MRI,
which makes sense.
Again, if you look at our triangle, you kind of work your way up the risk factors. Ultimately, what you want to decide at the end of the day is, do they have the substrate that would predispose them to cardiac arrest, which in electrophysiology is fibrosis.
So the MRI wasn't to confirm if there is MR or not, it was just for substrate.
Just for substrate.
Because a lot of these patients are sent for MRIs to confirm if there is MR.
Is there really MR?
Or
how much is this?
Exactly. If they can't see it on the...
So you're saying, so we had 2 risk factors, which you would agree with, and now the next step is to see if you've got scar, and where is the scar, right?
Well, I guess I would say 3 risk factors: female gender, complex ectomy, and as well as MAD.
Okay. So you need to change that to 3 risk factors.
That's true.
No, but you're creating...
And she's in the right age range for it. So she gets a cardiac MRI. They call that there's LGE in the basal infroseptum. Now, obviously we don't do the MRI ourselves, but we would believe that, although we'd more commonly see it in the basal inferolateral region.
Okay.
Like the classic mitral valve prolapse scar pattern is basal inferolateral. What we've learned from our own imaging studies is that when patients have unileaflet prolapse, they tend to have the classic mitral valve prolapse scar pattern, which is basal inferolateral. When they have bileaflet prolapse, they can actually have a patchy distribution of scar, almost to the point that if you weren't paying attention to the prolapse, you would assume they have some other substrate like sarcoidosis. In fact, a lot of our hybrid PET MRIs have a very typical pattern that you'd almost be misdiagnosed as cardiac sarcoidosis if you didn't realize that this also occurs in bileaflet prolapse.
So it's diffuse?
So it's patchy. In our own experience, it's been patchy in the bileaflet prolapse patients, very focal in the unileaflet prolapse patients.
Is the distribution for the patchy still same, or is it all, is it?
It tends to be septal, some anterior, and some basal and inferolateral.
Okay, all right.
So
what's interesting is that almost makes you wonder if that goes to the question of, because people have always asked, why is bileaflet prolapse higher risk than unileaflet prolapse? Like, what would be the difference? If you look at it from an electrophysiology perspective, and we know this from the non-ischemic literature for many years, when you have a patchy distribution of scar in a non-ischemic patient, they are much higher risk for sudden death than if they have just focal replacement fibrosis. So maybe that's one of the reasons their distribution of scar places them at higher risk for future ventricular arrhythmias.
All right, so what happens here?
Okay, so the question comes up, of course, do you do additional imaging at this point? Do you just observe? Do you give her beta blockers and antiarrhythmics?
I mean, she just came to see you because you being an internist or a cardiologist, because she has ectopy. Now, you're telling her that we need to look further because this could potentially be a risk factor to you for other events?
Correct. We know that she has a risk for sudden death. What we don't know is
she has prolapse. Right. She has all these.
Okay.
So what is her risk? Like when they ask, "What is my annual risk?"
Yeah, I'd like to know what's my risk of having sudden death.
Correct.
What's the best you could tell me?
I could tell you that on the highest end, it's 2% per year. On the lowest end, it's 0.3% per year.
So that's a significant difference.
Right. I wouldn't get on a plane for a 1.8% risk of crashing.
You don't want to be that 1%.
No, I got that.
Right.
So I think the question is, can we modify this? Can we modify the severity of the ectopy? There's no MR to correct at this point.
Well, I think what she's asking is, can we modify her risk for sudden death?
I don't care about the MR.
Yeah.
I don't want to die.
Yes. So what I'm saying is that there's nothing more to control but that the ectopy and how that can.
Because most people would say what we said at the outset. It's I've got MR, so I need surgery on my valve.
Yeah, this doesn't apply here.
It's mild MR.
She has now done her reading. She's gone online. Right. She recognizes that as soon as she types in the word mitral valve prolapse or an arrhythmia, the first 50 articles will be about the risk of cardiac arrest. So she now comes to an electrophysiologist or a cardiologist and she says, what do I do?
Well, if I know more information, can it be treated? And that would be outside of putting an ICD is a big deal.
It's a big decision, and we obviously we cannot be putting ICDs.
That's the treat when the engine's.
And until recently, there was no guideline recommendation for this in the absence of significant.
So what I'm asking is, there are other things I can do to clarify her risk?
Personally, at this point, I don't think additional imaging moves the needle.
Would an EP study change it?
So that's a good question. Does an EP study predict risk? And the answer is we don't know. And there's no clear consensus on whether or not an EP study is either sensitive or specific for the risk of future sudden death in patients with prolapse. We know that in other substrates, EP study generally is not predictive of risk.
So you're telling me that 1, 2, and 4 are not going to help us much, that I've either got to choose from 3 or 5. Is that right?
Well, 2, observation is a reasonable strategy.
I don't want to be observed if I've got a risk of dying suddenly.
Well, you don't want to, but for 20 years, that's what people were doing.
No, I understand that, but I'm just saying.
Until they became
I think the real question is number 3 or number 5.
Yeah.
Do you give beta blockers? Again, we give beta blockers to people with ectopy. What impact it has, we do not know.
Okay.
But it is recommended to give them beta blockers.
Let's move on so we can.
Or ICD. And ICD is a big step.
Okay. No, it is a big step.
So this was the consult note. I just want to read it at the outside hospital just to show you how this field has progressed in the last few years. You would have never seen a consult note like this in 2019.
Okay.
That's just an example. So I'm just going to read it for you. Her MRI findings, echo, and case were reviewed in the EP attending conference. given her high-risk features, most everybody was comfortable, including me, in recommending a defibrillator. So the patient actually took this opinion, got a second opinion. The second opinion said it sounds quite reasonable.
And it did?
And then they opted to have the primary prevention ICD implanted,
so
which for a young woman is a big lifestyle
It's still
change.
a big deal. Yeah,
Correct.
I think it's a responsible choice because she has mileage ahead of her.
Yes, but there's hundreds of thousands of patients similar. So when we put in, for example, I'll just give you hypertrophic cardiomyopathy. The old thinking used to be everyone with hypertrophic cardiomyopathy should get an ICD because they're at risk. Nowadays, we only put in ICDs for patients with an annual risk more than 1%, and we have a risk score to achieve that.
Right. No, I know.
Right? You have to have a certain septal size or a certain syncope, or you have to have apical aneurysm.
So for most people, if I have it again, if I have VFib or something, this will shock me out of it. So this is giving me a little bit of insurance, or a lot of insurance.
But we have to be careful that we don't over-implant.
Okay, go ahead.
So this patient agreed and underwent a dual-chamber ICD implant on February 15th, 2023.
Which was about 3 or 4 months ago.
Correct.
Okay.
And then on March 7th, and this is an electrogram from the ICD, the patient had a PVC that initiated here ventricular fibrillation.
And this is her first VFib, right?
Correct.
First documented VFib.
And she goes into ventricular fibrillation, as you can see here on the RV channel, and she appropriately gets defibrillated out of it.
Now she's had an episode.
Correct.
So what do we do
the right
now?
choice was made in this particular patient. So after this, in addition to the beta blocker she was already on, flecainide, which is an antiarrhythmic, was started, hopefully to suppress the PVCs. How effective that is, I don't know. And then 2 weeks later, she had another shock for the same thing, PVC-induced VTVF. So twice now in a short period of time, she was saved by the defibrillator. Again, this is just an extreme example of someone who got lucky.
But she's now really anxious over this.
Right. So
and I
now,
don't blame her.
Now the question becomes, okay, so you saved her life. She's happy about that. She absolutely hates the idea of being defibrillated, right?
Okay.
She can avoid it. So now the question comes up, do you just add a new antiarrhythmic? She's obviously too young for amiodarone. Do you offer her, again, if you remember that triangle on the outside, catheter ablation of the PVCs? Hopefully that if you remove the trigger, then you remove her recurrent ICD shocks. It doesn't necessarily remove all her risk, but it can reduce the risk of future events. Do you offer her mitral valve surgery or mitral valve surgery plus PVC ablation?
But she's still got mild MR, doesn't she?
Correct. And I think if this patient had moderate to severe or severe MR, then 3 and 4 would be the right answer.
Certainly.
Right? But with
But
mild
with her,
MR,
it looks like 2 is the right answer.
2 would be the correct answer.
Okay,
so that's what we offered her, catheter ablation of PVCs. And what I want to show you here is just an example of how much more we're learning as the process goes on. So this is what's called a scar map of the left ventricle. What you see here is
and green is bad?
Well, purple is healthy tissue. This is the endocardium. Okay. And then this is the endocardium, what's called a unipolar map. This looks at the epicardial surface of the heart. Here is the mitral valve. Here's the apex of the heart. And so you can imagine that the papillary muscle is right about here. All of this green tissue here is epicardial fibrosis. So even though the MRI doesn't identify replacement fibrosis, she clearly has interstitial fibrosis in a location that would be expected for mitral valve disease, mitral valve prolapse, showing again that her substrate, even though her MR is mild, her substrate is worse than just mild.
Okay, got it.
And this would explain why she is obviously able to perpetuate ventricular fibrillation.
So what do we do now?
Well, so she's been treated for catheter ablation of PVCs, and so now it's just basically a waiting game. Eventually, we'll wean off her medications, and we're hoping that by removing the trigger, we've removed her future ICD shocks. And it could be another 20 years before she needs mitral valve surgery.
If she had moderate or worse MR, then she might have had surgery early on when the thinking was if you get rid of that.
But in the presence of MR, yes, that would be a modifying factor. The question is, because of the complexity of the ectopy, whether the correction of the MR would actually have a benefit to the ectopy.
I'm going back to her. So if she had moderate or more MR, then surgical correction of the MR, mitral valve repair, with ablation at the time of that would also be an option. Is that correct?
Correct.
Okay.
Even if you have, in this case, more than one foci.
Right, because here she has at least 2 foci, but at least one of them involves the papillary muscle. You can do an ablation there, and the hope is that the other one
might be in the aortic curtain?
Exactly.
Yeah.
So that can be addressed by the mitral.
So where do we stand? Because I mean, this is fabulous. It's really good, and I've learned a lot of stuff. Where do we stand with our knowledge? Do you have a summary now of this? I know you've got MRI. You have MRI with inflammation, and I want to see that because that's important.
So I have a different case, which I think gets to the question of, how do you manage these patients with ablation versus surgery, and or both of them at the same time? If you think about mitral valve disease and ventricular ectopy as two different mechanisms, then your therapy has to be focused on that. Mm-hmm. So as an example, you asked about, do you just do mitral valve surgery, you just do ablation? So if you, for example, here in this scheme right here, if a patient has prolapse and mechanical traction and they've already developed their fibrosis, so they've already developed their scar, then if you just fix the mitral valve, then all you've done is really affected this pathway here to get to your ventricular arrhythmias. This pathway here is still present. So in our particular experience here, if we can affect both this pathway with ablation and this pathway by fixing the mitral valve, then we should be able to block all the future ventricular arrhythmias.
But again, you need to have enough MR to do surgical intervention. Is that correct?
Correct.
Mm-hmm. Okay. But also, I think it's important to add that correcting the mitral regurgitation is not removing just the mechanical traction forces. It also improves the intraventricular hemodynamics. This ventricle has been chronically loaded, and it has, by way of the prolapse itself, abnormal vorticity of the way that the blood flows into the ventricle and moves out of it. By correcting it, we actually alleviate those hemodynamic forces, those shear stresses that affect and trigger inflammatory pathways that are contributory into the genesis or substantiation of perpetuation of arrhythmia.
You showed an MRI and PET scan. I mean, those are elegant. Now you're really adding another level. Is that needed in patients?
I think for risk stratification, an MRI is needed.
Yeah, right.
I don't think you can risk stratify without an MRI. I think hybrid PET MRI is useful, is adjunctive for risk stratification, but not absolutely necessary, obviously. Although it is useful for peri-surgical planning, I think, because it can actually help us identify the location of the ventricular ectopy. And just to give you this example here, since you brought it up, this is a patient who had a hybrid PET MRI whose PVCs were not papillary muscle, so doing a papillary muscle ablation during mitral valve surgery would not be appropriate. Their inflammation localized, as you see here, just to the AMC region.
Yeah,
and the PVCs on the 12-lead EKG were classic AMC appearing PVCs. Okay. So in a patient like this, if you are going to perform mitral valve surgery and you have the opportunity to perform ablation, focal ablation in that location, you can probably affect the PVCs more than just fixing the valves.
So the take-home messages are many, but you told me a couple of facts that are really important. You have a risk profile of patients.
A checklist that we go through.
The triangle in there, and you have those. That the degree of MR is not the deciding factor. It's important if you're going to think about a surgical approach. Or that
it's not reassuring, I would say.
Correct, okay, that's good. That knowing where the PVCs are coming from and looking at the extent of scar in the ventricle is really important.
Correct.
So in this woman, knowing what you know now, after she's had two, would you have treated her differently? In other words, we all agree that the ICD was the right thing to go, but knowing what you know from her now, would you have gone in, if you'd looked at the burden of scar, would you done something differently?
It's hard to know with a retroscope what,
I know. Okay. But treating her loci, I mean, with ablation was absolutely the right thing to do.
Because now what we're doing is treating symptoms. Her symptoms are her ICD therapies. She's not going to have sudden death because she has a defibrillator. But we still have to actually treat the ICD shocks.
And you modify the risk factor, definitely modify the risk factor like this.
So is this data now available to the common cardiologist to know? I mean, you've taken us through a whole bunch of stuff, because there still is a lot of, the number of papers on mitral annular disjunction are just out there like crazy.
There is a lot more information available, and there's, I know that the American Heart Association and American College of Cardiology, both here in the States and the European societies, have started an immense effort to inform institutions and physicians about the risk, and both with workshops and other media.
Yeah. I mean, I think
mostly to educate patients.
Yeah, no, I think it's and physicians though. I mean, I think it's really important. You all, again, going back to the concept that you've got a team approach to arrhythmias, and to Dr. Adams and his team's compliment, they've got you integrated into this as the EP expert. But you've got a team approach, which is really good for patients because it allows really more knowledge to their problem.
Yeah, and I think to that point is actually very important. We used to have a slide where we showed, at least here at Mount Sinai, which is you have the cardiac surgeon, you have the cardiac imager, you have the electrophysiologist, and they all kind of work as a team together. And the important part is that who's ever on that team sees a lot of these patients over the course of many years, because over time you start to identify, you can kind of almost sniff out who's the higher risk patient.
Yeah, this reminds me of that patient I saw and all that.
Yeah, you have to have a systematic approach to addressing these patients, because although they're obviously quite different in their risk factors, the patterns are relatively similar, the patients who will have complications from their prolapse.
And even perioperatively, we've effectively modified the way that we induce anesthesia, the way we take care of this patient during surgery, not per se
because
the operative management.
Main stressor.
Of course.
Right,
so from the induction point, all of the way that we can reduce the surge of catecholamic and surge, we modify the induction, very deep narcotic anesthesia, very diligent control of your potassium, magnesium, both during and afterwards, euvolemia. And these are all steps, very small steps that are very crucial to not only to take the patient through the operating period,
safely.
but exactly after because we do have Marc who immediately gets to see the patient the moment he goes into the intensive care unit, but that period, the post-operative, acute post-operative period is very important.
I'm thinking of patients who've had events during induction.
Yeah. I think in the future you'll see actual arrhythmic mitral valve prolapse centers, like places that
That's
do
what I was going to add, my final thing. So you've in essence developed that.
We hope so, yeah.
Yeah, so I think that's important. And that's an important thing. That's an important thing for the audience to know. This has been really, really good and very informative. It's a lengthy discussion, but a timely discussion, I think, really important. So, I compliment, the colleagues at Mount Sinai who've developed this, and the knowledge is really, really important, some pretty dramatic knowledge, so thanks. I've learned something. I hope that you've enjoyed this and learned as much as I have, and certainly you know now where you could refer patients if you need to. I'm not making a pitch for referral, but a lot of knowledge, and it's really important because these patients, I'm sure, are extremely concerned about their risk. So thank you both for doing that. Thank you for joining us.